introduction, and then we have this great panel here who's going to solve everything. And again, I overpromise and underdeliver. But one of my major concerns is in public policy and politics in general, if conservatives don't get ahead of healthcare, other people are going to make decisions and come up with bad decisions. Exactly. And that is a significant concern for us in a variety of different ways. And having lived in other types of healthcare systems throughout the world, a lot of them really are quite bad. It's well intended, but they end up having unintended consequences we'll talk a little bit more about. Healthcare is complex for a variety of reasons. One is each of us has our own medical issues. And then with multiple layers, what's a primary care, acute care, long-term chronic care, all these things add on to it with thousands of regulations at a variety of different levels. So in three large areas, one is access, one is how soon you can get in to see a primary care. Some places 2-3 months. How far of a drive is it to actually get more rural health care, for example? Then there's affordability, enough said. And then there's quality. You can solve some of these things. And one way of you hurt quality, well, we're going to improve access and affordability by making it cheap and fast and bad. So all these things together become quite complex with it. And then, of course, healthcare is quite expensive. And there's a lot of resistance to reforming of it. So this has to be reformed. It's not going to reform on its own. So our panel today, the three great people here, if some of you guys saw the drama earlier this morning, it's kind of thrown off our schedule a little bit, so we'll blame the other guys. But first of all, right here is Dr. Zafran with the Texas Medical Board. So he's from Houston, president of the Texas Medical Board, board-certified anesthesiologist, and we have many anesthesiologists here today, so I'm outnumbered. He's the vice chair of the Clinical Governance Board of U.S. Anesthesia Partners for the Gulf Coast region, as well as member of the Clinical Governance Board of the U.S. Anesthesia Partners in Texas. He serves on the board of directors of the FDA Analgesia and Anesthesia Drug Product Advisory Committee. He's also served as subcommittee chair in the U.S. Department of Health and Human Services Pain Management Task Force. Many of my patients appreciate it. And then Dr. Zafran, he studied biochemistry at the University of Texas at Austin. And then, I'll get something out of that. And finished medical school and residency at the University of Texas McGovern School of Medicine in medical school in Houston. And he is the current chair of the Texas Medical Board. So welcome, Dr. Zafran. And the next here we have Honorable Lacey Hall, Texas State Representative of Texas 138. And Chair Lacey Hall is a native Houstonian who was born and raised in Houston District 138, attended Spring Branch ISD schools, and is a University of Houston graduate. During the 88th legislature, Chair Hall was reappointed to serve on the House Committee on Human Services and Insurance. She worked on legislation to support and protect the rights of families, very important for you. And ensure that Medicaid patients with serious mental illnesses maintain access to prescription medications. She's chair of the House Committee on Human Services for the 89th legislature, and prior to being elected to the Texas House, she worked with a variety of nonprofits to advocate for policies that protect the liberties of Texas families. And then, so Representative Carolyn Harris-Davila proudly served Texans in the House District 52, born and raised in Round Rock. Caroline's lifelong Texan who understands and champions Texas values. That's why I came to Texas. She was named the GOP Freshman Legislative of the Year in her first session as state representative. And Representative Harris-Davila successfully passed into law SB 490, which furthers medical transparency and requires medical providers to issue itemized billing statements to all patients. She holds a bachelor's degree in communication from Thomas Edison State College and a master's degree in public affairs from the LBJ School at the University of Texas, Austin. So I always get confused being a foreigner from Missouri. Who wears burnt orange and who wears burgundy? Oh boy. I might have to leave Texas. So. Yep. Well, I'll start with you right here, Dr. Zafran. We've discussed several areas of concern. We're just trying to solve some of these problems first thing this morning. One of the issues in medicine is what we call vertical integration. It's becoming more and more consolidated. I'm actually an independent physician, one of 3, I think, left in the country. It's a bit of an exaggeration, but about 70% of physicians are actually now hospital employed. And now there's benefits and problems with that. But the vertical integration does increase problems in independent care, and I think one of the things that's driving healthcare costs up. So teeing up that way, Dr. Zafran.
Yeah, thank you, and thanks for having us here. Great morning, even though it's a little cold outside. You know, with the regulation of medicine becoming such a complex type of environment where physicians really don't have the time to take care of their patients, but they're typically doing a lot of administrative work, you've seen quite a bit of consolidation in the marketplace in the healthcare side. And what I've always talked about is making sure that with any kind of consolidation, you've got to make sure that the incentives are aligned. And the incentives in healthcare should always be about making sure that we're able to take care of the patient. That should always be the first and foremost incentive that is out there. But what you've been seeing with vertical integration is a consolidation that may not necessarily be aligned that way. And I kind of use the example of the PBMs, where you're having a mirroring effect of that, but on the physician side. The largest employer of physicians in the country right now is actually an insurance company, United Healthcare with Optum. Now, I'm not saying that's a bad or a good thing, I'm just stating that out as a fact. But when you look at the aligned incentives or the non-aligned incentives with that, you have an entity that it is in their interest to provide less care that is overseeing somebody who's trying to provide care. I mean, it's almost like prior authorization or non-prior authorization on steroids. The person who's doing the prior authorization is overseeing the person providing care. So you have one structure there that is being integrated in a way that is not necessarily aligned. The other structure that you're seeing is healthcare systems owning or employing physicians also. It's also a very different type of aligned incentives because healthcare systems are actually incentivized to maybe provide too much care. And I always kind of use the example of the CT scans. You know, somebody who works for an insurance company may say, I only want you to do 5 a week. The person who works for a healthcare system may say, I want you to do 20. The right answer is really what's necessary for the patient. And that's where the aligned incentive comes in. And that's where we kind of go back to the physician always has to be the one making sure that they're making the decisions on how healthcare is being provided. So regardless of what kind of consolidated system you have out there, whether it's vertical integration, whether it's horizontal integration, whatever it might be, there's got to be a mechanism to where the physician is the one who is making the decision and nobody's overseeing or second guessing what that decision is as far as taking care of a patient. And unfortunately, that's kind of what we're seeing right now. Again, it's kind of like the PBMs. You know, it's funny when I was trying to prescribe Celebrex to a patient of mine for postoperative care, you know, they told me what, you know, the insurance cost of it is something like $300. I looked up on GoodRx, and the cost of it is something like $10. PBM, non-PBM. And it's a very good stark example. You can look it up yourself. You know, you can just pull up the GoodRx thing, and not that I'm promoting GoodRx or anything like that, but it's an example of what the non-insured cost is. In many instances, it's lower than the cost of actually going through insurance. So PBM, mirrored on the other side with vertical integration, where you're having an entity that is not aligned with the patient's interest making those decisions. So the point that we always make is that if you're going to have consolidation, consolidation is going to be necessary. You know, if you're starting to look at accountable care organizations that were existing in the past or direct primary care, whatever it is that's out there, if you're going to have metrics that look at quality, that look at a whole bunch of other things, there's going to have to be an entity there that helps create a business model to help develop that, to help report those metrics. And that's fine, so long as at the end of the day, we're making sure that the end decision-making process is always about making sure that you're taking care of the patient and not somebody else's aligned interest.
It's a very, very simple problem with all the rest of it. PBMs, real quick, is pharmacy benefit managers. You know, we talk this language all the time. Pharmacy benefit managers are essentially the middlemen between the pharmaceutical manufacturers and actually getting it to you as the patient. And they're designed, the original concept was that they actually help lower costs. What has in fact happened is essentially pay to play. If you're a pharmaceutical and you want to get something on a formulary, you have to basically pay a rebate is one term, a clawback's another term, a variety of other ways. But basically they're allowed to do this because they got exemption in the 90s from the anti-kickback legislation. Yeah, it's a kickback. So it does cause these other problems with the PBM. So Optum, Caremark, and Express Scripts, these are some of the big PBMs that we commonly use that phrase, and they have an effect, a significant effect on all these particular costs. So I had a pre-authorization denial of Xofluza, which is an influenza drug. So it'd take me 24 to 36 hours to get it. By then it's not, you have to start it in the first 48 hours of the flu. So it was again, that pointless. They wanted the person to try different medications, unless they paid cash for it, which was new drug, $200. So, Madam Chair, you like that title? So, dovetailing off of that, we were talking a bit earlier about value-based care and metrics to what are the qualities for it. So, direct primary care, which is I think I do value-based care every day. When I was an Army physician, we had the hospital commander was a helicopter pilot, and he was looking at the metrics, and he wanted the metrics to look good so he can get promoted. So I was judged on metrics. I wasn't judged indirectly. One would hope that would be the quality of the care, but it actually caused problems with it. So how do we make value-based care work?
Well, can you hear me? Yes. So last session we tried the bill and we made some changes to it because I know we wanted to make sure that we didn't affect any specialists because that was not the goal of the bill. The goal is only primary care. So we were approached by primary care physicians. So this is not related to emergency care or any specialist. And so the goal is to have primary care physicians, if it is their choice, to enter into an agreement with the insurer, ones that are the state regulated commercial market, to provide value-based care, so to see patients at a capitated rate. And the goal is to provide more stability with everyone knows the cost, what the amount is going to be, and to hopefully provide more care and more people being able to see their primary care physicians a whole lot easier and better. The goal is, we know that emergency care is so expensive and so many people do not receive primary care and they end up in the emergency room, which costs a ton of money. And so it is just one piece of the puzzle of how do we increase the people of Texas receiving primary care and not ending up in the emergency room. So, but it's just obviously one part of that.
One part is, a lot of this is just getting around the edges. Sometimes it just takes a long time with a lot of different things.
Yes.
Improvement by 1,000 cuts, so to speak, if I may misuse that terminology.
And you said, so you do it, but not with insurance. And
correct.
And I know some other primary care doctors who do the same. So this would just allow the option of it being an insurance type.
And I tell a lot of people, I make a joke that I watch Young Frankenstein. I don't do brain surgery. So when people come to my clinic, can you do everything? Well, no, but I can do a lot of it. And primary care, it's very simply, is 90% of medicine. And I tell people explicitly I do urgent care as well, so they don't go down to an urgent care clinic when they come to my clinic. But who goes to primary care to get, they sprain their ankle? You can't get in. It speaks to access as well. But even though I do 90% of medicine, it's 5-10% of the cost. 5 to 10% of medicine is 99% of the cost. And that's where that huge expenses come into. But if we can actually improve value-based, we improve that care front end, it's a 90% reduction in ER visits. We see that quite a bit.
And we see value-based care already in Medicaid and Medicare as well.
Right, and then some of those work better. Here's an odd thing. We were just talking about this earlier. I've opted out of Medicare, which makes it easier to see Medicare patients. I'm like, what? Yeah. So I cannot bill Medicare because I've opted out of it. So now I can have a private contract with someone who's otherwise eligible for Medicare. So it's regulations. There's a lot of well-intended ideas with regulations, but as we were chatting earlier, there's a lot of unintended consequences of good ideas. But when you go to the ER, sometimes that bill's quite high. So Representative Harris-Davila, I thought on transparency, a lot of people suddenly go up with costs. I had a patient the other day went in, and it was a very simple thing that I could have done for maybe $20 or $30 in terms of just splitting material, and I'm getting a $5,000 bill. Lots of stories like that.
Yes, a lot of stories like that. And so going back to the bill that we worked on, let me ask real quick, have any of y'all had a medical procedure within like the past couple months? Anybody? Okay, did you get an itemized statement before you paid for it? All right, well, clearly we have some more work to do, but but the bill that I should say the House passed last session and the Senate went into law last year was, before you pay anything after your medical procedure at a hospital or facility, they have to give you an itemized statement. Has to have the billing codes, a plain language description, so that if you don't know the medical jargon, you know exactly the care they provided to you, and then the price is next to it. And one of the reasons why I became so passionate about this is I was working on it as a staffer when I worked for Senator Hughes. I worked for 2 years in the House, 6 in the Senate before I ran for office. And I was working on it with him, and I faced so many obstacles in working on it as a staffer with him to get it passed. I mean, it made no sense to me. It's basically a receipt. You get a receipt when you go to the grocery store, when you get your car work done. I mean, every other aspect of life, you get a receipt. And we pay a lot of money for healthcare. So of all things, we should get a receipt for that, right? And so I discovered when I was running for office that in my district, I had constituents who were being sued for medical bills, in some cases less than $5,000. And they would go to court, but they were never given an itemized statement. And so when they said, I already paid for this part, or I never received this care or whatever, they had no document to point to or anything like that. And so it was just their word against the hospitals. And so in most of these cases, they ended up paying. And these were people like a single mom with 3 kids going on a payment plan to pay off something that she didn't even know was accurate, right? And so that just gave me even more fuel to get this done. And when we were working on the bill, I guess I should say after we passed the bill, I have had people come up to me crying, saying, thank you so much for at least helping us consumers have an idea of what's going on with our healthcare, because I really think that all of us would be more engaged with healthcare if it weren't so complicated. And that also helps, or I shouldn't say helps, the complication is another reason for why prices are so high. If there were more transparency, we could actually see what the price of healthcare is. It wouldn't be that expensive, but it's because it's so complicated that you can just hide, what all those expenses are. And so I'm very passionate about getting consumers more engaged with the system. How can you work on that? This session, we're tweaking that bill a little bit because clearly not all of you are getting itemized statements. But part of that is a lot of people, the hospital or facility will send the itemized through a portal because that's how we put it in law last time. Well, some people, even me, don't have the portal set up. And so you're not going to see that. And so we're tweaking it this session, trying to make it to where you have to be asked, how do you want it? Do you want it mailed to you, emailed to you, sent through the portal? What will that look like? And I'm thrilled to be able to work on the transparency, but I am so hoping for a day when we can have a healthcare system that has more free market principles infused to it, more competition. It's reformed by 1,000 cuts. And I'm so thrilled that we got the bill passed last session. It was the last day. It took a lot of work. I'm so grateful for members like Lazy Hole who helped me with that, but I'm going to keep working on it.
It is very difficult. We all have those similar stories for it. And so I went to see a dermatologist that I used to send referrals to. Quick little bill sent in, and then they said, oh, I have Army TRICARE. And so it was billed to TRICARE, and a statement of billing or statement of benefits, which is just monopoly money. It's just used for negotiation purposes. And then all of a sudden I got a note on my credit card that an extra $60 or so had been charged. So I called up, what happened? Well, they didn't pay us enough, so we just billed your card automatically. It was my mistake to give them my credit card ahead of uptime. They just billed it automatically. And so for an extra $50, $60, whatever it was, which annoyed the hell out of me, that's $1 million to a lot of people who are in the lower income.
Yeah.
And so they lost a lot of referrals.
And real quick, I'm just going to tell this story. I was knocking on doors this past time I was campaigning, and I knocked on one of my neighbor's doors. And I told them I was working on this issue, and she said, oh my gosh, I'm so glad. And she said the last kid that they had, she ended up going into labor in the car. And so they had the kid on the side of the road. They get to the hospital, they took care of him. The kiddo was fine. But she said they got the bill, and they were billed for a delivery room, for a delivery nurse, for all these things. And so they disputed it, right? They're like, well, we never had a delivery room. Well, the hospital said, well, can you prove it? And they were like, sure enough. So they had to get the video from the hospital security camera showing her coming in with the baby to show, hey, we came in with our child, So, and I say that, I'm not here to talk about, hospitals are horrible or anything like that. That's just a story of how the system is broken and how much we need to fix it. But anyway, yeah.
follow-on question from that, 2 points is, one, if you get these crazy bills, argue it. And a guy wrote a book a couple years ago called Never Pay the First Bill. And it's because they're just throwing it out to see what you do. It's not the doctors, it's not the nurses, it's not, who are all the staff there. It's all these, it's just the marketing. That's what we do. That's the AI, the dark side of AI. Helps you read x-rays, but also helps billing faster. So how do we enforce it? I mean, how do we make certain they're doing it? We can pass a rule. We can get laws and regulations added. How do we make certain they do it?
Well, from the physician side, if there's any kind of disclosures that are not appropriately done, for example, a physician that may have ownership in a laboratory, and we used to see quite a bit of complaints where people were getting laboratories done for thousands of dollars. May have been like some DNA sequencing to determine if you are more susceptible to one kind of medication versus another, that kind of stuff, which is fine so long as it's disclosed to the patient and they agree and they understand and they consent to it. But when that doesn't happen, then certainly that's a violation of the Medical Practice Act, at least from the physician standpoint. So when we get those complaints and we're able to show that the patient did not consent appropriately and were not disclosed appropriately, and a disclosure doesn't mean that you have a sign behind the coffee machine that nobody can see. It has to be something that is very obvious, and they need to actually sign that they understand, that they know that they're, the physician may have ownership of the MRI, or they may have ownership of the laboratory, whatever it is, and go ahead and make sure that when they're billed for that, that it's not something of a surprise. So in instances like that, we as a medical board can actually oversee and have sanctions on the physician and tell them you cannot do that, and that's a violation of the Medical Practice Act. So from that standpoint, there's oversight. Now, of course, in the hospital system, DSHS oversees them. If it's a pharmacy that is not disclosing appropriately, that there are other options out there. And I say that with the caveat that in some PBM type of contracts, they're not allowed to disclose that there's an alternative unless the patient specifically asks. But the patient doesn't know to specifically ask unless they know to specifically ask. It's kind of like a whole catch-22. So that's where the oversight comes. But again, the nuances and the devil's always in the details. But from, again, like the physician standpoint, disclosure and transparency, at least with what the physician has oversight over, is mandatory. And it's interesting about the transparency side because from the standpoint of the No Surprise Act, there is transparency clauses, at least from the federal side of things. Now, how well is that enforced? Not very well. And there's obviously a lot of opportunity there. So everywhere where we can kind of enhance and encourage that, I think it's going to be important.
Yeah, and I'm just going to add, we very specifically in the bill last session put in there that you can't collect debt. So there can be no debt collections, very specific definition, because if you haven't paid your bill and it gets transferred to a third-party billing system or something like that, they legally cannot collect that from you or harass you about it or whatever until you've gotten an itemized statement for those charges. And we get calls all the time in my office because people hear about the bill and they're having problems with this. And in one case, I'm looking at my chief of staff over here, in one case she called one of the third-party debt collectors and said, hey, our constituent had not received an itemized statement. And they said, oh, okay, well, we'll just leave it alone then. We're just not going to do anything. We're just leaving it alone. So it's really the knowledge, though. I mean, I don't know how many people know that they have that power to ask for an itemized statement if they don't get it. So that's the other part, is people just give up because they assume it's complicated. Consumers just give up right away. And so that is another thing we need to work on, is just helping consumers understand really the power they have in the market.
Yeah. Kind of to add on to what you're saying, and this kind of brings me back full circle to the whole thing about consolidation, because it fits into this. We have many issues where sometimes the patient, wanting to have transparency, will ask for their medical record. So they have a right to their medical record. It has to be given within a certain amount of time, and it should only have a reasonable fee. But the problem is, who owns the medical record? And we've had many instances where the physician says, I want to be able to give it to you, but the healthcare system that I worked for is the one that owns it, and I don't have access to it, which by law, they're supposed to have access to it. And we get into this little tizzy about who has ownership. It's supposed to be the physician, but who's employing the physician, who has access to it, And it becomes very difficult because now you're getting into this whole structure of, well, we don't have, the medical board doesn't have, regulatory authority over the hospital that may be the one employing the physician that has ownership of the records that they're supposed. So you can see how this becomes very complicated and very nuanced. And obviously a little bit of clarity on who has authority over who would be very helpful.
If you need more power, ask these ladies here to the left.
She's my constituent. I mean, sorry, I'm her constituent. I'm her constituent. I'm her constituent.
So one
Yes.
way I get around that actually is I have patients who do a release of records, and I'll find out where they had what hospital they're at, who their primary care, and they'll electronically send. We use faxes still in medicine. It's electronic faxes, which seems so 20th century, where it came from. But so I get all those records, and so when we electronically fax, they send us a big PDF file. Then I just turn around and give it to the patient. But for a lot of people, I tell them, don't try and get the medical records yourself. Let us help you out. So we find a way around it, but it becomes a real challenge.
I was going to add that is very interesting information, because in the Human Services Committee, we hear and deal with all the time parents not being able to access their children's records, especially when they're involved in a CPS case. And so it's constant problems. And so it's so interesting to hear that, because people are always wondering, what is the holdup? What is the problem? And sometimes they don't get the complete records. Things are left out. So that is fascinating. We'll have to try to figure that out. Yes. Yes.
I might have some language for you. I don't know.
Perfect. Perfect.
So we'll talk later.
On the transparency cost, for example, as you guys are saying, and your staff's no doubt working on a lot of it, ask first. And a lot of people don't know this, you're here because you're interested in these, how to fix healthcare. So this audience, of course, is much more active in being involved in it. So many other people aren't, for example. And then trying to understand the cost. Everyone thinks healthcare is supposed to be expensive. So regularly, I guarantee a large lab, nationwide lab. We get our labs, we draw them in our clinic. People come pick them up. I guarantee them payment. And then the lab gives me the wholesale cost, and I just pass that on. So it's actually quite easy to actually give them wholesale costs. And it's 10%, not 10% off, it's 10%. So it's significantly cheaper than you think. Now in an ER, for example, when someone's going to the ER and they have chest pain, was the chest pain because they're playing, took a fastball in the chest, or are they having a heart attack? Well, the ER doesn't know. So they have to do worst is first, and they have to do all these different things. And that's more expensive, quite understandably. However, all kinds of things get added on, like your maternity case.
Yep.
There's no delivery there.
No, and I think really we're the consumer is paying for the healthcare, right? And I don't know how many of you know this, but 1 in 10 Americans have some form of medical debt. And to me, now all that I know about the medical field and how much things cost and stuff like that is so frustrating to me that people are going into debt over money that they may not even have to spend. And especially talking about the ER, if we could, get more primary care docs, and if we could get more independent physicians, if we could increase all that, we wouldn't have the ER problems. We wouldn't have people spending all the money on that. And this is an idea for another day, but I would love to see medical schools talk a little bit more about how do you become an independent practitioner. I mean, I don't think that they talk about that. I think it's just assumed, okay, I'm going into all this debt for medical school. I'm going to go work for a hospital so I could pay that off. And, and it is a great career. I am not saying anything against that at all. It is wonderful. I'm just saying, I really wish you were not 1 in 3 independent practitioners in the United States, because we need more, and I don't know how we get there, but.
Well, there's an easy answer to that.
Okay.
Relatively easy. Decrease the I said relatively easy, but decrease the complexity of healthcare, because we were part of a small anesthesia group, just kind of, speaking about myself, back in 1996. We came together, was Greater Houston Anesthesiology, and back then there was Hillary Care in 1996, and in response to that, I didn't say I liked it, but in response to that, we had to consolidate. We were 3 different groups. It was Methodist Hospital, Memorial Hermann Southwest. It wasn't Memorial Hermann back then. It was just Southwest and St. Luke's. And we became one group to be able to actually respond to the drive to make HMOs the standard of care back then. So that was consolidation, but it was still physician-run and physician-driven. Fast forward to 2012 and you had the Affordable Care Act. And again, more regulations, more things that the physicians had to do, more cost. And the only way to be able to respond to that, again, kind of going back to what we said at the very beginning, was only three ways. Either physicians had to band together and become larger, or you had to be owned by a healthcare system or by an insurance company. Because that small independent practitioner, the cost of actually providing care became so burdensome, not because you're providing care and that's expensive, but because of the regulatory environment around it became so expensive. What you are mandated to do, what you were mandated to report became so expensive. So that's why you saw an acceleration of consolidation in the marketplace. And one of the things that I try to tell my physician colleagues is, if you're going to consolidate, do so, but make sure that in doing so, it is going to be physician-led and physician-driven, and preferably physician-owned. So you do see consolidation out there, but if you've seen one, you've seen one. And it's not necessarily that it's a bad thing, because you do have to respond to the marketplace, but if you're going to do so, at least do so to where that physician-patient relationship is sacrament and nobody's actually telling or mandating what the physician is going to do as far as helping take care of a patient, that is something that is helped, that is held sacrament between the physician and the patient themselves. What we've seen so many times right now, and this is something that frustrates me, especially when it was around the abortion bill, is that there was a period of time last year where the bill specifically exempts ectopic pregnancies, but you had patients going to hospitals in the Dallas area, I'm not going to name which hospitals, that were being told, send the patient home and we're going to wait until the ectopic bursts and then we'll treat it. And then they blame the bill. I'm like, what? No, that's not right. You know, you're supposed to actually take care of the patient. First of all, the hospital has no business telling the ER doc or the OBGYN what you can or can't do. That's number one. And number two, follow the law. The law doesn't say just send them back home and have them come back. And then don't blame these legislators for what they did that was correct because of something that you didn't follow to begin with. So all these nuances, I think it's very important for all of us to understand and then to apply the law as it was written. And that's something that we as a medical board try to do all the time, but it becomes a little frustrating because what's set out there, how folks interpret it becomes the norm as opposed to what should be done, which is saving the patient's life, doing what's right, making sure that that physician-patient relationship is held sacrament.
Yeah, interference, regulatory interference is why I do private practice. You know, it's about 90% less administrative burden by doing it. It's that much. Which is just insane. But your comment about we should be studying a little business in med school. We learn how to write badly. Yeah, but it's true. We learn business in residency on the side essentially, and so there really isn't much training for it. Other types of training actually does include business training, and I think that's an essential part of any of that aspect of it. And then when you have the whole regulatory vertical integration leads to other people making decisions. And one thought, a great bill would say everyone in healthcare has to take the Hippocratic Oath. So whether that actually creates a fiduciary responsibility and more moral behavior, well, we'll see.
That brings up a point I think that's really important. This is a bill that Dr. Oliverson was thinking about doing in the past and it just became so complex, but it brings up a very important point. So when you talk about prior authorizations and who's making the decision on providing health care, what we as a medical board said that we should be doing is that physician who's working for the insurance company, and a lot of times it may not be a physician, it may be AI, but who's holding them accountable to the standard of care when they're deciding on making payment. And from my standpoint, if you're deciding on making payment, you're actually deciding on providing care or not providing care in this kind of healthcare environment. So we talked for a while about making it to where those physicians who are deciding prior authorizations were held accountable to the standard of care, and they could lose their license if they didn't. But again, how you operationalize it is where all the complexity lies. But again, kind of going back to holding those accountable to, for those who are making decisions on how they're providing care and so forth, which in many instances today are non-physicians.
It becomes a real challenge, because these are abused on the other side as well. What that exact balance is, or I don't like a balance between extremes because you sometimes get the worst of both. But rather is find some really good solutions because every so often you hear cases of a Medicare fraud and 10 physicians in handcuffs are being let out of their clinic out of Florida. Seems a lot more, but you get those type of abuses on it. Now, also in terms of access, just to segue a little bit, we're talking about how do we increase the number of physicians, not just with business training in one form or the other, but we did talk a little about making an easier pathway for international physicians. And there's a clinic not too far from here that does retinal research, and the gentleman who does the photography, so what is he taking a picture of? It's very advanced photography of the retina. He also draws the labs. He's actually a Chinese trained physician. And he chose to actually take pictures of retinas for the research study and teach the young medical assistants how to do lab draws, and he's perfectly happy. He is not becoming a physician because he'd have to go back to residency, and he may not, his prior medical degree may not quite meet our standards, but there are opportunities. There's cardiologists in England, France, and Germany, other parts of the world, Japan, who are very highly trained, and they have to go back to residency where they're all of a sudden they're going from salary where they're making $150,000, $200,000, $300,000, whatever it is in other countries, to 40, and then going right back down. How many of you want to go back to high school? That's residency in a nutshell. But there's opportunities to do that, and we have a couple bills coming forward for that.
Well, not only are they competing for, not only are they going back to take a residency, but they're competing for very limited spots, because we don't have a lot more GME spots that are out there. So that's part of it, is that number one, they have to go back and do their residency, but number two, there's not that many spots out there. So you don't want to take away from the U.S. medical grad having a residency spot, but there are opportunities out there. I mean, I'll give the quick story of when I was a resident. One of my faculty members was a guy from South Africa, outstanding guy, and he was an IMG. We have a type of license called a faculty temporary license, an FTL, and they can operate in an ACGME type setting, an accredited facility in that type of environment. Now, this guy could not practice anywhere outside of that facility, but he was training residents. When he wanted to become a fully licensed physician, that guy who was training us for about 10 years, ending up having to go back and do his residency, do those 4 years, and then come back and be an independent anesthesiologist who could practice outside of the facility. I'm giving that as an example of we have a lot of wasted resources out there of folks who can actually become licensed physicians so long as we put the appropriate guardrails around it. There are great physicians out there who are acting as surgical assistants, or some of them may be Uber drivers, and you talk to them and these guys were practicing for 5 to 10 years. On the flip side of it, you want to make sure that there's not the unintended consequences of creating two different tiers of physicians or licensure out there. So there are 9, maybe I think 10 states out there that have started this pathway of alternate pathways to licensure. There's an advisory council that involves all the appropriate stakeholders, CMS, ACGME, the FSMB, the Federation of State Medical Boards, and many others, and a lot of the state medical boards, in making sure that we look at the nuances in creating that pathway, but expanding access at the same time. Also making sure that we have a pathway for board eligibility, because you don't want to create a pathway that you have a fully licensed physician who's not board eligible, even though they may have practiced surgery for many, many years, but may not be able to get credentialed in any facility because they're not board eligible, so they're kind of hanging out there in no man's land. So it's a process, I think, that's in place. I think we've got a lot of good language that is being proposed out there with Senator Sparks, and I think on your side, you guys have several bills that are out there, and we're going to have that conversation about making sure that we kind of fine-tune and learn from the mistakes that some of the other states have made and are going back and revisiting it and come up with a pathway that does expand access, take some of these great trained physicians, but do it in a way that doesn't minimize the licensure that we already have.
And I may get this figure wrong, but just if you kind of zoom out on Texas and how fast we're growing and what our needs really are, by 2030, I think we're going to have I think we're going to need 32,000 primary care doctors that are not there right now. And so part of the reason why, I do have one of the bills, I think Dr. Oliverson has another one, to try to get more of these people in other countries to come over and get integrated in our medical system faster. And I recently met with some folks at one of the hospitals in my district, and they said that they cannot find doctors for pediatric dermatology, which is a very unique thing, I know, but they take trips overseas and try to recruit doctors in that field specifically because they're at a children's hospital, and that's a need that they have that's just not being filled by our medical system in the US or in Texas. And so part of my bill is, if a hospital finds someone who is, licensed in the other country, has been practicing for a certain amount of time, just these standards, right? They fit the standards. Then they can come in and start practicing at the hospital, verified job offer, clearing all these things, and start working already and filling that need. And then at the same time, that counts towards their, process of becoming board certified, whatever that looks like. But we need those options because, in the United States, it costs $200,000 or more to become a doctor, right? Something around there. And yeah, that's the low end, right? Exactly. And let's not talk about inflation, but for pediatric dermatology, I think you maybe get paid, $90,000 a year or something. It's not one of those things that everybody signs up to go do unless they're very passionate, because they've got the debt that they've got to think about and paying that off in their family and all these things, right? And so how do we open up the state, making sure that we do have the right guardrails, right? That they have a similar medical background as you would find in the U.S. at U.S. medical schools. But we need that. I mean, we're so behind on how much need we have just in Texas. I'm sure it's worse in the entire U.S., but that's the goal behind our bill, and I know Dr. Oliverson's bill is just getting more doctors integrated, because these are great doctors. I have friends who are doctors from other countries that came to the U.S., and it was so difficult for them to start practicing that they went to medical school again and residency again, and they paid all that money again because it was just the regulatory burden, it was just so difficult for them to try to get in and practice. So that's what we're trying to avoid, right? We're trying to open it up, make sure that all of these people are qualified, but get more people integrated into the system faster.
Madam Chair, any thoughts on expanding access?
A couple. One of the options, and I'm not sure who has the bill this session, is loan forgiveness for healthcare providers if they move and serve in high needs areas. We did it I think it was last session for mental health providers. And so, I mean, that's just one part of the conversation as well. It's like all of you have said, it's like a 10,000 things to try and help solve this problem. So that's one. I also think increasing nurse practitioners to help with primary care they do well women's and exams and certain primary care needs, and then they refer to different physicians or specialties when needed. Again, I think it's just one part of the conversation, but I've seen nurse practitioners for things over the years and had great care, and know other people who have as well. And so, again, I think it's something that could really help, especially in some of these underserved areas that are in dire need of primary care.
One of the challenges is getting people to those underserved areas, whether it's inner city or the more rural areas, where the market just is so difficult for them to start up. How can we help that?
I think there's things. I had a bill last session that House and Senate passed, and I'm so glad that the governor signed. And it's specifically for people on Medicaid who are high risk. We started with high risk pregnant women, and the goal is to connect them with services that already exist in the community, like transportation. How do we help these women get the care that they need, and that it doesn't cost the state extra money? The services already exist, and that helps to end up providing better care and lower the cost of their health care when they're actually receiving prenatal care and are going to their appointments. And sometimes it could be your specific question was on transportation, but it could be anything from food instability, they're not able, they're homeless, whatever it may be. And so it's looking at all of these different things to make sure that people can access care and are healthy, which obviously, again, lowers the cost of healthcare, especially when it's the taxpayers that are paying for it. How do we provide better care and save taxpayer dollars? And I think we've made a lot of changes I know just in the last couple sessions that I've been there, we've made some great changes to do just that. So.
Yeah, I have actually a PA and a nurse practitioner who work for me, and then I have a collaborative agreement with another nurse practitioner she's setting up her own direct primary care clinic. So there are opportunities are out there, but again, what are the regulatory barriers to go out to these other smaller areas? If you're relying on Medicare and Medicaid in a smaller town, it's quite difficult to actually make all these things work because of the administrative burden and how much you're getting reimbursed. And then, so there's all kinds of silly things are done. I knew a physician when I was a younger physician, a long time ago. He required people to come back to get refills for simple blood pressure medicines so he could redo a chart so he could do the billing, because it's the only way he could actually make ends meet in his small clinic. And so that type of fee for service, in order to meet the market requirements, was doing bad medicine.
Yeah, I guess one of the things that I would just add in there is that, we obviously have geographic hurdles. We have economic hurdles, and I wonder, and I think it's important for us to kind of like maybe look at the data in some other states, that if we do grant expanded scope, will that really increase the number of people who are in those areas? Because those economic hurdles and those geographic hurdles are still going to be there. I know that several years ago or several sessions ago, we passed, or you guys passed, some expanded language that allowed for, I don't want to say less oversight, but more oversight by telemedicine means, so that the geographic barriers as far as the oversight was kind of removed. So at least from the standpoint of having a physician have oversight, that was made a little bit less onerous. What we've seen and what I get a lot of concerns about, and many of you may have heard of the hydration clinic in the Dallas area where there was a physician overseeing it who happened to be 200 miles away, and we dealt with that. But you had somebody who decided that adding several other types of things other than fluid was going to be something that may be okay. This happened to be a journalist who was the patient. And ended up going into cardiac arrest and dying. There's a thing called, obviously all of you have heard of potassium. Potassium is something important in our body, but if you give it too fast or too much, it stops your heart. It's actually what is used in death row. I didn't say we use it. Because what they do is they give a medicine to put a patient to sleep, and then they give very high dose of potassium in order to stop the heart, which is actually what ends the person's life. So in that one instant, there was a supplement that this person decided to give to this journalist that had a very high amount of potassium in it, and it was given over a period of 15 minutes. And for those of you docs who know that if you give potassium in 15 minutes without it being monitored closely, it can do very bad things, like stopping a person's heart. And that's what we kind of, I guess, worry about, is that we've seen this proliferation of undersupervised, I'm not going to say unsupervised because this person was supposed to be supervised, but undersupervised type of cash pay things proliferating out there, med spas, ketamine clinics, all these kind of things. And the worry is that as we expand access and maybe the oversight is not as clear as it should be, that we're going to start seeing more and more of these things. And the worry is that these are areas where we as a medical board may not have the ability to regulate or have any kind of oversight. Now, we have oversight over the physician who was supervising, and that person lost his license for a period of time. But the other person who wasn't even a nurse, I believe, I think it was just a medical assistant, we ended up having to give her a cease and desist in practicing medicine without a license, but eventually she ended up getting prosecuted by the DA and so forth and so on. So two things I would say is, number one, is it increasing access? Are we actually increasing the number of people who are going to go into those areas? And number two, and I think we had this discussion at a Senate hearing earlier in the year, is who has oversight? And are you going to actually have two standards of care? One of the things that I said is that it's important that you have one standard of care, and the oversight being from the medical board. So if you are going to give, even today, if nurse practitioners or PAs, and PAs, by the way, already are under the medical board, or they're a sub board of the medical board, is at least it should come from one entity. And that way you're not having two different standards of care. The other thing that I think is really important is that when a physician is sanctioned, whether they have a remedial plan or an agreed order, that's very clear on their profile. And in fact, it gets sent out to all the physicians that, we call it the naughty list. It comes out once a quarter. And there's a list of physicians on there that have been sanctioned by the board. It's a very public profile, and it's very important for patients to be able to go and see, this is the physician I'm going to go see, has anything been done on them? And it's clear what it is. I mean, everybody can make mistakes, and that's what remedial plans are for. So if something happened 10 years ago, actually the remedial plan would have been removed off of their profile because it's only there for 5 years, but at least it's there. And one of the things that I would argue for is that as we look at non-physicians providing care, is that not only do you have that single standard, but you also have that transparency, like we talked about with cost, but also on actions that were taken. So that number one, it's easy for a patient to know if there's an overseeing physician with a nurse practitioner, who is that overseeing physician? And I think I know there's a rule that we passed that made it mandatory for the physician to mandate that when they're supervising that they have their name on there. But the other part is, if sanctions were taken, that it's clear and transparent to the patient who the overseeing physician is, and if there are any sanctions, that it's clear on the profile that it's out there.
So real quick, we can't get through this panel without talking about COVID-19, okay? We just can't. But I want to talk about that a little bit from, if you just, 10,000 feet view, right? During COVID, we saw where the government was kind of like pushing everybody towards more healthcare, right? Which is, that was needed. We didn't know what was going on at the time, all these things. But I do think it was a golden opportunity for us, I'm kind of going into this quality piece of things, to talk about, okay, what if you were higher risk for COVID? One of the things was if you were overweight or something like that, right? And so the government had a golden opportunity to say, all right, this is how much a 20-minute walk every day could help you. This is how much a 20-minute walk 3 days of the week could help you. This is how much getting 20 minutes of sunshine a day can improve your health. I mean, there are so many things like that out there that I feel like have just been lost because everybody is talking about healthcare and new medicine and drugs and procedures and all that, which is great. The U.S. leads in innovation, and I'm very, grateful for that. But when you talk about, people that set up clinics and, have these unique ideas and stuff like that, it's partially because the government has pushed people so far in terms of all of this innovation that they're now trying to look for other options. They're looking for these other clinics and these other people providing these other things, and they take advantage of that. And so when we talk about quality, we really, in government, and it shouldn't be government, but we need to do a better job of explaining, okay, yes, this will help you, but also, what a 20-minute walk 3 days a week help you? How is that going to lower your risk for COVID? All these things that are free, by the way. That's the other thing that, you've got to you got to pay for everything for COVID, but we didn't talk anything about your diet and all these free things you could have been doing to make your health better so that even if you got COVID, you could handle it better. And I'm still frustrated that we missed that opportunity, but that is something that we need to do better on so that people don't get taken in by people presenting new ideas and stuff like that, people are driven more towards those now because everything else looks so complicated and, they just feel pushed into a corner to take all the medicines and everything else.
No, you're absolutely right. And one thing that we did that actually was a result of COVID is, all of you know that telemedicine was utilized a lot more during COVID, and we wanted to try to take advantage of some ideas, especially around access. So one of the things that the medical board passed a year and a half ago was what we call a gold status around opioid management. And one of the things that we found a lot of patients telling us that they were very frustrated by is that in order to get a prescription for an opioid, they actually had to physically see the physician every single time. And, you could only prescribe it 1 month at a time, so you can imagine if you're in a rural area or in a low access area that it would be very difficult and very burdensome to be able to do that. So what we did is we came up with a structure that allowed the collaboration between the primary care doctor in that area along with a chronic pain specialist in an urban area, along with a psychiatrist if there was a substance use disorder, and along others, if they collaborated and made sure that the patient was able to access their medications with that collaboration, that we held them harmless from an audit for a period of 5 years, unless they had a specific complaint against them. So that's one of the things that we try to do, is take some of those ideas during COVID with telemedicine and others, come up with new structures and new scenarios with a proper amount of oversight, but maybe creative ways of helping provide that care so a patient who had chronic pain is not having to go to a physician if it's driving 60, 70, 80 miles every month in order to be able to do so.
All right, question and answer time. We could have gone on COVID for a long time.
Sorry.
And so you guys have the question at the back. We'll start there. Hi, Tanner. The only thing I'll say is, to use Kevin Roberts' phrase, please make your statement in the form of a question.
Question mark at the end too. I think this is mostly for Dr. Zafran. I was wondering, can you give us a breakdown of what everything's looking like when it comes to physicians? Like how many folks are retiring, how many folks are doing residency but aren't actually getting licensed in the state? Like just a little update would be awesome.
Yeah, so one of the things that is worrisome is that our population is aging. So the number of people going into Medicare is significantly going up. I can specifically speak about anesthesiology, but this kind of goes across the board. But the average anesthesiologist age right now, I believe, is 55, 56. And many of them have said that they plan on retiring over the next 4 or 5 years. The number of people going into residency spots, even though those are limited, that number has gone down, along with the overall population of the country going up. So you've got this whole, it's not even a trifecta, it's a quadrifecta. The population's aging, the number of people is expanding, the number of physicians retiring is going up, and the number of physicians coming out of choosing to go into medical school because of the burdensome cost and so forth is going down. And that's why the ideas about the alternative licensure is something that we're looking at, because there's some way we've got to be able to increase that denominator. I mean, the math is there, but we want to be able to do so, of course, with that oversight to make sure that we're not decreasing quality. A lot of great docs out there. We just want to make sure that we create that pathway that has that mix of oversight but expanding access at the same time.
And I'm not trying to turn this into a longer discussion, but there is also the aspect of having DEI in medical schools. You know, Harvard no longer requires the MCAT for entrance. They're moving away from that. You know, even though that sounds a little crazy, but those are other reasons why people are not entering medical school and deciding to practice medicine, because they want to practice medicine. They don't care what you look like. I don't care what my doctor looks like as long as he's good at his job. And so that's another thing that we need to tackle, right? Yeah, or hers, you're right. I do have a female doctor. But yeah, so that's another topic that we do not have time to discuss. I just want you to know that that's out there. That's something that we also need to work on, is making sure that medical school in particular is based on meritocracy.
We call that Orwellian Marxist racism. That's actually how you find DEI. And so we have another question right over there.
Hi, I'm Michael Hewitt from Dallas. Going back to the beginning of the program, I think you talked about prescription drugs and lowering the cost of them. What would you like to see, if anything, from the Texas House in the future on that subject, and maybe the representatives can answer?
There is a bill. So was it last session we had a bill to allow agreements with Canada to get better prescription drugs from Canada, an agreement directly with Texas and Canada. This session, there's another bill that's been filed to do that directly with the UK. So just for the state to be able to contract directly, or I guess people in the state to be able to contract directly with them, and that's good for a number of reasons. It's cheaper, but it also just kind of takes away some of our reliability on China and the stuff that they produce. So we did get that done on the Canadian side. Now we're working on the UK, and you may have some more to add.
I can't remember if it was last session or the session before. Dr. Oliverson passed a bill that had to do with prescription drugs and using the rebates putting it into this big fund. You know what I'm talking about? Yeah. And so was that maybe 2 sessions ago? Okay, last session. So it didn't use taxpayer dollars. It used the rebates. And the goal of that was to help people with uninsured or underinsured who could not afford their prescription drugs to be able to use that. And I don't know where that's at in implementation. So now I want to find out where that's at. But it seemed like a great, again, one piece of the puzzle.
Yeah, prescription drugs is complex because new drugs, in order to develop, require a lot of money and many years. Someone said Ozempic, for example, says that's only been around for a couple years. No, it's been in development for almost 20. And so how long it takes. So how do we get that cheaper for people who really benefit from it? I'm not certain of the answer yet. We'll figure that out next session, but or next one. But here, I was too far on the left, so I decided to move to the right. But just to give you an example, and I'll get you next. Just an example of metformin and lisinopril, for example, wholesale cost is $1 a month, and I get a patient who's paying $10 copay for, I get a generic, it's $10 copay a month. Like, dude, that costs $1. And so that 900% increase is all this whole system of PBMs and kickbacks. So it's a real challenge, not just generic. So, sir.
So I want to thank you very much for your efforts in promoting transparency. I think so many of the problems we have in healthcare, from nursing profiles to the distortion that we see in vertical integration, all come down to the root of poor transparency. However, we can draft all the legislation we want, but if we don't put enforcement mechanisms in to ensure that it's happening. For instance, I had a fusion back in January, and everything I signed was on a little signature pad with the monitor towards the other person. So I didn't get to see a single thing that they were describing. They just said, this is what you're signing now. This is what you're signing now. And that's not transparency. And I don't think that's the intent of the legislation that you passed. So my question for you is, how can we ensure that going forward, legislation has teeth to enforce what your intent is?
Well, I'm going to start by saying it's very difficult to get a bill passed through the Texas legislature, and I'm very glad that our founding fathers set it up that way, because I think we can all agree we want less government. But when I was working on that bill, I had to take out, so I had a penalty in there, a pretty significant penalty, financial penalty for the facilities that were not complying with the bill. And when it got right down to it, to get the bill passed, I had to take that part out. That's what I was told, otherwise it wouldn't pass. So I'm still working on that. I think that the debt collection piece is still a really good mechanism, even though, again, you have to, make sure everybody has the knowledge to act on that. So that, it is more difficult. It's not the teeth that I wanted, but don't worry, I'm still working on it. We'll get there. Thank you.
We're talking about price transparency, and you said earlier that the healthcare industry is not the free market, and it's very obvious. So I decided to I have a 1-year-old. I decided to have him at a birth center, and with that option, it was the free market. I walked in, I knew exactly how much birth was going to cost, knew exactly how much my prenatal and postnatal care was going to cost. I was able to pay it all up front, got no surprise bills. While my friends who go the more traditional route and have birth at a hospital, they have no clue how much it's going to cost. They have no idea. They don't get a choice. And they get surprise bills for the next 2 years. And so I'm just wondering, obviously, the birth center route, they figured out how to do the free market, how to have healthcare and free market. And so I'm just wondering why hospitals, I'm not in the industry, so I don't really understand. Why can't the hospital understand how much a birth is going to cost, how much the care is going to cost?
Yeah, well, we could have another whole panel on that. But it's interesting because in healthcare, the federal government does a lot of these changes. Like President Trump was all about the price transparency and no surprise billing, and even President Biden had some ideas on that too. And so there are some changes that are coming based on that, but it just takes time a lot of times for those to get implemented. I have a bill this session that says if you're getting a good faith estimate, so if you call a hospital and you say, hey, can you tell me how much my birth is going to be, and give them the details, and then you call another hospital, another one, they will give you the estimate, but there's no ceiling on what they can charge you when you actually go. So even if you pick a cheaper place or option, they can still bill you for whatever they want to, and it says in their language, this is just an estimate, you may get charged more, right? And so the bill I'm working on this session says that they can't charge 5% more than the estimate they give you, and that's just to give, again, the consumer more clarity when they're trying to shop, when they're trying to figure these things out, plan their life out. And these are just basic things, right? Like a knee surgery, having a birth. And that bill also says if something happens, like if you have a complication or something like that, totally fine, as long as you've got, it documented and you let the patient know, hey, this is why we had to charge you more. Here's what happened. We had to do a blood transfusion, whatever that looks like. But that's just another way, again, to try to give families, especially moms, especially more peace of mind to be able to plan out, okay, this is how much this birth is going to cost, this is what it's going to look like. So that's one bill I'm working on. There again, the federal government's working on a lot of that stuff too, but
Yeah, your health is essentially a monopoly against yourself. And, some guys will take advantage of it in many different ways. The fountain of youth is for sale. It doesn't work. But we had a question back there, I think it was. Yeah, that one right there. I moved back to the left.
Thank you for that. I want to follow up on your comment because I am in the industry. And one of the great problems of transparency starts with what's your starting number? Chargemaster, which no one pays, is the easiest for a medical practice to calculate. The hospital nearest me, I just met with their CFO 2 weeks ago, and the hospitals that we own are outside the country, which operate in a much more transparent kind of a manner. But he has 51 different negotiated rates. So it's virtually impossible for anyone in the hospital to tell you what you're going to pay. They can tell you what they're going to charge, sort of, but they can't tell you what you're going to pay because those departments are disconnected, largely because of regulation. It's a problem that is significant. But my question for the panel is this. Access, particularly in Texas, is very difficult, as you commented. One of the issues that arose out of the Affordable Care Act is the rise and now maintenance of skinny networks. Very small networks, which work to the disadvantage of anyone outside urban Texas. You can't get to a doctor in your network. I happen to live in rural Texas. I now have an appointment for a gastro appointment on August the 7th, which is crazy. What is the legislature, if anything, looking at in terms of expanding network access for folks? And then the second element to that is Medicare and Medicaid, CMMS, are working counter to that by giving credit to rural hospitals for not keeping patients overnight. It really is, it's talk about goals that are at odds with one another. I'd be interested in your reaction to that.
We did a bill on network adequacy, I believe it was last session. I'm struggling to remember the details of that right now.
So a bill on network adequacy was passed where TDI, Texas Department of Insurance, was mandated to do an audit because beforehand it was a self-audit by the insurers that would report back to TDI, I think it was every couple of years. There was funding given by the legislature to TDI that actually forced them to do an audit of the insurers to make sure that they had an adequate network based on the specialties and the population and the geographic area of the population that they were serving also. I think there's a proposed network adequacy bill out there this year to even tighten that up even further to make sure that the numbers, the actual real numbers of providers in that area is something that the insurance companies can't fiddle with too much. There is an enforcement mechanism. One of the things that has been a little bit of a struggle is that there's a network waiver that insurance companies can ask TDI for. You can only ask for it, I think, 3 times. I can't remember if it's 2 or 3 times the max that you could do it. And what those metrics are, it's supposed to be good faith negotiations with the providers, again, some other struggles that they may have had in actually having that network. Now, these are for state-regulated plans, right, because you don't have any kind of oversight over ERISA, but TDI has the ability to sanction and put certain fines on them or delicense them as far as the state-regulated plans are concerned.
And I would say, yes, it is a problem in rural Texas, but it's also a problem in urban Texas too, because again, it's just, yes, and I think it's another part of the vertical integration that we're just dealing with right now.
Well, we're getting close to time here, and we could talk about COVID a lot. But your comments on that actually remind, like, a lot of the basis of medicine really comes back to some very simple things. And people ask me, what's the best? I got the flu. What's the best electrolyte solution? It's still chicken soup. It has all the electrolytes and actually has nutrition in it. And then, healthy diet, exercise, clean living, and do what your mama told you. That kind of really comes down to it. But as we're wrapping up here, any final comments from my esteemed colleagues here?
One other bill I want to point out that I am working on is that healthy school lunches bill. So I heard a ton about this in my district, and so we're working on it with Senator Hughes. And I also know that Senator Colkhorst is going to have a MAHA day in her committee. So that'll be one of the bills. So I encourage any of you guys, if you're interested in that, to keep tabs on her committee so you can go testify for that stuff.
Yeah, I'm also very excited about all the MAHA movement. I feel like I was MAHA before it was okay to be MAHA, so I'm very pumped up about it. But it's about just the basics, and when we're talking about the cost of healthcare, if people take better care of themselves and the education around that and know what to do, we can bring down the cost of healthcare. And the other thing that I think when we in human services we do Medicaid, so we see the fiscal note on bills, but in insurance you don't see the cost. So if we knew the cost when we do things in the insurance world, that how it would cost the consumer, the employers, all of that, and if there was a fiscal note attached like there was with Medicaid, maybe we would make some better choices. So it's very interesting. But yeah, thank you all.
Yeah, one of the things I think that would be so important for making America healthy again is making sure that physicians have that opportunity to have that conversation with their patients. A 10-minute conversation is not enough, and that's what they're forced to do. But if you're being burdened with looking at a computer, filling out an EMR, and not actually speaking with your patient and talking about, what's a healthy diet, what's a good exercise, but you're worried about, am I going to meet my quota in my 10 minutes because I have to see X number of patients in a period of an hour, no matter what we do, we're never going to be able to solve that problem. Getting back to the basics of that physician-patient relationship, where you can have that conversation and have patients that trust their physicians and are able to, talk about, here's my struggles, how can I make myself healthy, what do I need to do? I'm having, struggles with mental health issues. I'm having struggles because I just had a child, I'm having postpartum depression. All these things were communications that were happening that we're kind of losing it right now because we're so much into that regulatory burden that we're forgetting to actually talk with each other as opposed to talking at each other.
Yeah, the challenges in this type of medicine really makes a lot of this stuff worse. And live a healthy life. Something will go on. Doctors will always be employed. There's always something going on. But how are you ultimately going to fix this? Patients want it. All the healthcare professionals of every type want it. So how do you make that work? The old saying is, how did they reform taxi cab systems? They didn't. Someone invented Uber and Lyft. So free markets. All right. Everyone would do a round of applause for this fantastic panel.